Thank you, Sudeep. So we'll move on to the next talk on SICS in small pupil. So we all know that in India we have a lot of SICS surgeons, multiple. You can call it as the most popular surgery in India is MICS as far as number is concerned, and we get a lot of hard cataracts also, along with that small pupils. They are all a complex which you get at most of the times. So I have no financial interest in this presentation. So the problems in small pupil SICS especially is that we need a larger rhexis because we need to bring out the lens through that nucleus, because you can get away with a 4 millimeter rhexis in a phaco. You can do a phaco through that, and if you want later after IOL implantation, you can extend. But here you have to have a bigger one before you prolapse, and the whole nucleus has to come out through that rhexis. And especially when you have hard lenses and mature cataracts, these capsules are not very elastic, and you cannot expect a small rhexis to stretch. So here, this is what happens in a small pupil, and you have done a small rhexis, and you hydrodissect, and you want to prolapse this nucleus. You just now saw a pupillary snap. The pupil snaps if you do a forcible hydrodissection without decompressing, and the lens lifts up, and the fluid collects behind, and it snaps open the posterior capsule. So especially in SICS, when you cannot do a gentle, small, controlled hydrodissection so that the lens just rotates, we need to do a little forcible hydrodissection so that the lens becomes fully mobile, and even we need to prolapse the nucleus out. So the adequate rhexis for a nucleus is what is required in an SICS. So here we managed to take out the nucleus. Sometimes it drops just like that, but then because it came out, you will see that there was a definite posterior capsule rupture once I extend the pupil with the hooks, and then do a vitrectomy and complete. So here is one case where I would say that we would like to stretch the pupil and make sure that the pupil is amenable to your dilating devices. Either you use hooks or rings. It's better you stretch the pupil a little bit so that the sphincters are slightly loose, and small sphincter tears have already happened. So here, if you place the hooks later, this is not going to tear like what you saw in Sudeep's video. So if you have a rigid pupils like this, and if they are stretchable, if you stretch, they will make it irregular, give you slightly larger but loose sphincter so that it can be managed later. So here is one case. It is a 4 millimeter pupil, very, very huge nucleus. So here, without stretching devices, if you want to make it a large rhexis, definitely large rhexis, you have to make it go towards the periphery. So if you notice, now I am holding under the flap and try to do 2 or 3 strokes like that. Then it goes out. Now my strokes are towards the center. So then they come back in. And after that, I again direct my direction of pull towards the periphery. Especially if you hold underneath, just at the fold and even underneath the fold, you can do it bigger. So once that is done, I go through the cortex. So retract the pupil, retract the rhexis margin, and hook on the equator and bring out one pole. So one pole comes out. So the rhexis has been adequate, but the pupil is still not adequate. The nucleus is so huge that one side dilates and the other side constricts. So then the nucleus gets caught within the pupil, and that is how the lens is stuck within the pupil now. So now I put in cohesive viscoelastic, stretch the pupil well, and then hook onto the nucleus very well with the tip of the Sinskey going into the nucleus, and then rotate. See, now the whole 9 millimeter new lens is coming out through the pupil. So pupil is going to get stretched in these kind of cases, and you're going to get sphincter tears. So here I would like to show one case. Here the nucleus is hard, but it is thin. We would see that the chamber is not so deep. I have done an SICS wound, so my first incision is subincisional. So, and all my incisions are close to the limbus, if you notice. So here the pupil is stretched and the iris is almost in the same plane as the iris. There is no crowding of the anterior chamber. So if you go more corneal, you get more crowding. So here we need, in SICS, we need chamber volume. So here I can do a 6 millimeter clean 6 millimeter or even slightly bigger rhexis. That is what is required now. So with or without hydrodissection, you can prolapse this nucleus. This lens is almost fully nucleus. So once you rotate here, because the iris has been stretched in its plane, its own plane, there is a lot of space in the anterior chamber, and the whole nucleus I am able to prolapse into the anterior chamber. So I put Viscoat again on top of the lens and push the lens away from the incision and Visco behind the nucleus, and I deliver the nucleus. Make sure that you see the distal part of your vectis, because these kind of black nuclei you may not see, and you can even engage the iris and pull on the iris. So here I take out the hooks now. See, the pupil has been stretched, but that is not irregular looking. See, if you notice, it is not at all irregular looking. So this is how we can gently try to pull and slowly engage the hooks and slowly pull, so that they do not, if one hook you engage and then pull it full towards the angle, then the next one will cause the sphincter to tear very drastically. And here, if you notice, this is a harder cataract, thicker nucleus, and the chamber is shallower. Again, a limbal paracentesis, and I make a rhomboid one. So here again, you need to stain the capsule and make 6 millimeter minimum or 6.5 millimeter for this kind of huge hard nuclei. And then soft cataracts, you don't need to stretch it this much. So, and you can stretch it to for 5.5 millimeters and then try to do a rhexis. Here, after the rhexis, what I do is I remove one of the hooks, because my incisions are slightly corneal, and I extend the incision adequately so that the whole nucleus can come out. Here you need at least a 7.5 millimeter outer and an 8 to 9 millimeter internal opening. But if well constructed, all these incisions close very well, and if temporal, they don't cause much of astigmatism. And here you can notice I have delivered out almost 1/2 of the lens out above the iris. The other distal half is under the iris, but still I'm able to just pop it out into the anterior chamber with the vectis on. So with the 3 hooks on, I can still deliver out the lens very safely, and it has to be very gentle and controlled, because this is a very huge nucleus and should not rub on the endothelium. You have to use Viscoat, and after that I go in through the same opening with the hook, and then these hooks do not need more than 0.25 millimeters. See, 27 gauge needle opening is enough to get in these hooks. I don't have any financial interest, but Alcon makes these nowadays. It's not available. Similar ones are available with Aurolab, no financial interest. They are very thin, very malleable, and they go in through very small openings. And here also you can notice the pupil has come back to the small pupil size, but they are not, that has not been distorted too badly. So another case, this is the last one. This is a hypermature cataract. So the nucleus is going to be hard, but not as thick as we have in black cataracts. So here your rhexis need not be that very huge, but so I can still be 6 millimeters, because they are not elastic ones. So if the nucleus has to come out, it has to come out smoothly through this rhexis. It has to be according to the hardness. Now, after I prolapse 1/4 of the nucleus, I release the hooks. This is another way. See, you can, according to the size and the hardness of the nucleus, we can do it either way, without releasing. With releasing one, I have released 3 now. Only the distal, this one is there. So here the nucleus is not very hard, and the pupil has already been stretched, and the pupil size, the lens size is smaller, and we are able to manipulate it through the pupil and bring it out. So here the lens is delivered out. It is prolapsed into the anterior chamber. The hooks are still there too. The third one I have taken out, but basically the one which goes underneath your main incision can remain there. Doesn't matter. It doesn't. This doesn't get obstruct your nucleus delivery at all. The choice, lens of choice is yours. You can use a foldable or non-foldable, or the foldable without an injector, because I like injector because it delivers the implant into the anterior chamber. Here again, you can notice that the sphincter is slightly torn, but not as bad as we saw. So very thin, very atrophic pupils may tear like this. But then rhexis is the most important. And if you have a 6.5, you don't need to stretch it that very wide. And then you can even release or relax your hooks, so that the pupil already which has been stretched will definitely give way for the nucleus which you have seen now. Thank you very much.